So here, you don't have to remember this, but keep in mind, as I said earlier, the electrodes pick up the electrical activity of the heart and the diaphragm, so we see the QRS signal here, but this is what the raw data looks like. You'll never see this on the ventilator, but this is what the ventilator sees internally. So it sees all this what looks like noise, but it isn't noise because we see the QRS, and this fuzziness is the electrical activity of the diaphragm that the ventilator sees, and it's smaller than that of the electrical activity of the heart. Then the software then filters out the EKG signal, creating the pure EDI signals on all of the waveforms. Then it combines all that information to create one EDI, and then it displays, then gives you a display of the electrical activity, the contraction and the relaxation of the diaphragm on the ventilator. And then, so here's what ultimately what it will look like on the ventilator. So we have our pressure, flow, and volume waveforms, as you'll always see on the ventilator. And then down at the bottom we have contraction, relaxation of the diaphragm. So this is the EDI peak and the EDI minimum down here, which is shown to you over here in terms of microvolts. So wherever it took the reading, it was 5.5 microvolts was the peak, and the minimum was 0.3. So the minimum and the peak, and that's what you'll see. Now, while I have the slide up, notice the morphology or the shape of the electrical activity of the diaphragm. So as the EDI is going up, and this is the actual depolarization or electrical activity of the diaphragm, and notice it's got little bumps and little things in here, little plateaus and so on and so forth. But then look at the pressure wave that's created as a result of this. So you look up here, and as the gas and the flow going in, the flow is going in commensurate with the way the depolarization is occurring. The pressure is being created commensurate with the way this is going. So that kind of illustrates how the ventilator is actually following the delivery or the depolarization of the diaphragm to deliver flow and pressure consistent with the way the brain intended the flow and pressure to be delivered. And that's the perfect flow synchrony. And that's what causes the patient to go, I can relax. You know, I can sleep better, and there's studies that show that sleep is improved while you're on NAVA, and that's important for babies as well. So, and lastly, and then I'll switch to the ventilator and we'll take a little break, but one of the things that we'll want to do from just a technical standpoint is so the ventilator's running on a patient. You know, there's a little activity, a few people in the room, and you've got your catheter, you're getting it ready, and we want to test the integrity of the cable and the module. And to do that, on each one of the cables, you're going to see this thing that I call the doohickey. But the doohickey looks like this on the cable, and it's a cap, and it's really the test plug, so you just disconnect the plug, and then it slides on the cable. You take the end of the cable and basically plug it into the test plug and turn it until it drops in there. And when you do that, even if you're running, you're going to get a message on here. It says testing EDI module. Just lasts for a couple of seconds, or a few seconds, and then it says EDI module passed. Okay? And that just tests the electrical integrity of the system. It doesn't calibrate it. It doesn't do anything else like that. So it's a good idea to do that, because if the previous time you used it, if a nurse ran over the cable with the bed and putting it away or something like that, I always blame the nurses. I don't blame the respiratory therapists for things like that. The wire could have broken, and then you're getting all ready, and you go, what's going on? And you know, so it's a good idea to test it before. So we test it, and like I said, you can do it when it's running. Instead, when it's running, the little message will be on the side of the screen rather than the middle like it was just then. So here's the schematic of what we measure: the nose to the ear to the xiphoid process, calling that the next measurement. And then what we're going to do is we're going to do a little bit of a calculation initially, but as time goes on, you might not be doing this calculation, but this is all part of the newbie in-servicing. So the purpose of this calculation is, as I said, the nurse can just do nose, ears, eye, void, put it in, and she's in position to feed with, and that's might be all her concern is. But we want to make sure that the middle sets of electrodes are at the level of the diaphragm. So let's say we're using we're doing an adult, so 16 French, I've measured myself a number of times, my nose to the ear xiphoid is 60 centimeters. So if I was using a 16 French and we're going to go nasally, 60 centimeters times 90% is 54, and then adding back in 18 centimeters, I would be at, 72 or something like that. So then I'd say, okay, put the catheter to the 72 centimeter mark. The purpose of using the formula is that the formula smooths out anatomical differences between patients' heights, so that if we do this right, essentially 50% of the time the electrodes will be in the right position right from the get-go. But 50% of the time, even if we measure perfectly and do the calculation, we're going to have to adjust the catheter slightly according to what the ventilator tells us. Okay? But notice as we go lower, if you put in a 6 French 50, for example, let's say the measurement is 20 centimeters for the baby, 90% of 20 is 18, we add back in 3.5 centimeters, so we go 18, 19, 20, 21, 21.5, so we really end up only 1.5 centimeters more than what the original next measurement was. So even in the real small babies, 90% of 20 is 18, adding back in 2.5, we're only 0.5 centimeter off from our original next measurement. So you can see that you might then, after a while with babies, if you do it enough, say, just put it into the next measurement and we'll look at the ventilator and make an adjustment rather than getting our calculators out and all that and doing the measurement. But initially, it's a good idea to kind of, do it as if you first got out of school and you've got your teachers looking over your shoulders, making you're doing it right. And that's what the nurses did initially, but then after a while the nurses are just dropping catheters without even measuring, I'm sure. In each one of the boxes, there's a placard that comes in each one of the boxes in addition to the one that you would use to determine the size. Here in the placard has the nose and the mouth, and it has all the formulas for the different size catheters that you would use. And so this one is for the nose, but then if we go to the mouth, the only difference is that instead of 90%, we're using 80%, okay, because the mouth is closer to the point than the nose would be, but that's the only difference. So we wet the catheter, but it's already wet because we put the saline or water in the box, and then put the catheter in the patient, and then hook the end of the catheter to the cable, and then from there we then determine whether we're in the right position.
Smell, Jim.
So this was at Birmingham Children's, and so this is just the chart that we used to pick a catheter, and we put it in this baby. But this is what you'll see when I hook the simulator up. What we're going to be looking for when we put the catheter in is you see these 4 strips running across the screen, and you'll see how I get this on the ventilator. But see how the QRS signal is big at the top and gets smaller towards the bottom? And the P wave, we see the P wave at the top, and the P wave is here, and then it gets smaller, and then it disappears as we go further down. Well, that's the morphology that I was talking about in terms of the electrodes being further away from the heart the further down you go. So this gives us an indication, this big, small, small, smaller from top to bottom, that the catheter is at least in the ballpark as we describe it. It's in the stomach. Because if all the leads looked like this, for example, from top to bottom, they all looked this and didn't have a P wave, it might mean that the catheter simply got curled up in the back of the throat and all the electrodes are at the same level relative to the heart. So the QRS would be small. In which case you'd say something isn't right, they're all small, and the nurse pulls it out and kind of pops out the kid's nose, and then you got to reinsert it. So ideally we want to see a P wave actually disappear from top to bottom, that it goes away on the bottom. Another example could be that it curled up, so the QRS would be big up here and then smaller, and then big again because it comes back on itself. So that wouldn't be right either. The reason is that sometimes the blue, which is the EMG of the diaphragm, EDI, can still appear even though it's like this, because you get some noise occurring from the musculature and the thing, and you see, oh, but I see blue, but yet all the QRS looks all the same. And you go, wait a minute, you see blue, and in those cases, sometimes you see blue jump from here to down to here, then back up to here, and so on and so forth. And you say, something isn't right, and the reason it isn't because QRS is not right. We need to get the QRS right. And so once that, it tells us that we're in the ballpark. Then what we're going to end up doing is the blue, even we can't see the EDI on these waves because the EDI is so small relative to the size of the QRS. But the software can, and whenever the software sees the electrical activity of the diaphragm, the depolarization of the diaphragm, it paints it blue. So in this case, it's painting the electrical activity of blue on the middle sets of electrodes. Like this is electrode 1 and 2, 3 and 4, 5 and 6, 7 and 8 from top to bottom. So it's painting the blue because these electrodes that are giving us this strip are right at the level of the diaphragm, like the chart that I showed. If the blue was at the bottom 1 or the bottom 2, it would mean that the catheter isn't in quite far enough because the bottom electrodes are seeing the greatest signal strength, and we'd have to advance the catheter a little bit. Okay? If we put the catheter in too far, the upper electrodes are picking up the greatest signal strength, and so the blue would be at the top, and we'd have to pull it up a little bit. So a saying that we have is that when the blue is down, push it down, and when the blue is up, pull it up, and the blue will, be in the middle. Now, intuitively, if I didn't say that, you'd go, if I said, well, we always want the blue in the middle, and if the blue were down, you'd say, oh, I think we have to push it down further. We'd have to pull it up, to get the blue in the middle because the blue is down, so we have to pull it up. But it's really, if the blue is down here, you have to push it down, and then you'll see the blue move from here to the middle. Okay? And the blue is the electrical activity of the diaphragm. And then that translates down here to the bottom, and you'll see a better picture of this in a minute. But here's the beauty of using NAVA to its full potential when a patient is intubated. And you guys have seen this in the PICU in terms of the asynchrony associated with it, and all the asynchrony that I talked about, triggering asynchrony, flow asynchrony, and termination asynchrony. But with NAVA, here's what the EDI is. Okay, so here's the electrical activity of the diaphragm of this kid breathing, and here's the EDI of that kid down here. So remember I said normal was what? 10 to 15? So he's doing more work. You could see it by looking at this kid. But up until we did this demonstration for them, it was like, yeah, okay, yeah, he's working. He's on a ventilator. What do you expect? He's working. But the reason that he's working is this. So we can superimpose the diaphragmatic movement on top of the existing pressure wave that he's currently being ventilated with. So the baby's in SIMB, pressure control, pressure support, and so here's his diaphragm moving, and his diaphragm moves here, but he's not given the pressure support breath until here. Then the mandatory breath comes in, and he takes a breath here, but the mandatory breath doesn't trigger till here. Not a big difference there in terms of timing, but look, his diaphragm moves, and it moves again during the delivery of the mandatory breath. So how would you like it if the ventilator was giving you a breath and your diaphragm moved twice within the breath that the ventilator is giving? You'd be a little angry, you'd be arguing with the ventilator. Here it moved and the synchrony was off. Here, pretty good initiation, and we see that the neural eye time, in other words, the length of this is about the same as so our neural eye time is okay. But in some cases, we might have here's another one where, he's breathing twice within the delivery of the mandatory breath. So this is significant asynchrony. But up until having the ability to superimpose the EDI on top of the pressure wave, people walk, oh, he's breathing fine. Look, he's triggering the ventilator. There's your pressure support breath, and there's your mandatory pressure support. What's the big deal? I don't understand. This is just ventilation. This is the way. But then we do this, and we see that and this is causing him to work. So then, this is an older software version, so it didn't have all the backup, but these are the settings, and I'll explain that in a minute. But we, set him up in NAVA, and there he's on NAVA. Now, let me go back real quick. See what his tidal volume is? That's the tidal volume being delivered by the mandatory breaths, okay? And that's his work, the amount of electrical activity needed to produce that tidal volume. Now he's on NAVA. Look at his tidal volume. Look at the amount of work that he's doing to create that tidal volume now. Significantly less work to move the same volume. He's much more synchronous. I mean, he's perfectly synchronous because the EDI now is controlling the ventilators delivering the breath commensurate with the electrical activity of the diaphragm. There's no triggering delays, there's no flow delays, there's no termination delays. And this baby's rate, and look at his peak airway pressures. They're lower than they were to deliver that same, so there's less chance of BPD, less oxygen consumption. He was already at, I think he was already at 21%. Yeah, he was already at 21%. But nonetheless, he's using less oxygen because he's not arguing with the ventilator as much. So remember I said that sometimes the minimum here, this minimum, when he was up, see the minimum's up, is only because of, it wasn't necessarily because he was trying to inflate himself, because he was an older baby, but it was just because of the argument that was occurring. So he's all over the place, so his EDI minimum is up. So then when you improve synchrony, now this is an indication of that he doesn't have that chaotic breathing. But see, the PEEP is 6. So I asked the doctor if I could turn the PEEP down to 4. Immediately the EDI minimum went up, because what happened is the baby felt the lung not collapse, but just go down a little bit because I turned the PEEP from 6 to 4. So his brain then went, oh, I gotta not allow my diaphragm because I want to keep the FRC there. Then when I turned the PEEP back up to 6, the minimum went back down to 0 because he didn't have to maintain the tonic activity of the diaphragm anymore. So this is a really good illustration of the full extent of the full power of what NAVA can do. And then imagine from there decreasing, peak inflation pressures, improved ventilation, better sleep because they're not arguing with the ventilator. All those issues come along. And those are the things that once, at this point, articles started to be generated, and they started really looking at NAVA, and they started proving the things that are intuitive to us in terms of looking and saying, well, geez, if we've improved it this much, a lot of other things have to improve. So our patients, for lack of a better mode, on pressure control, being ventilated occasionally, he's triggering the ventilator. So we see the purple T up there, right? So he's triggering the ventilator, getting more of these, and let me turn the pressure control down to, so we get 18/5, okay? So we see there might be a little bit of a leak in our circuit because the flow, the volume waveform isn't coming back to baseline all the time. We're compensating for compressible volume, so the tidal volume delivered when I'm not touching the lung is about 6 cc's. That's a good volume for a 1 kilogram kid. So, but for whatever reason, we decide to put the baby onto NAVA. Or keep in mind also that you can use NAVA not as a mode, but simply to monitor what's going on with the diaphragm. Because if let's say you had to give a lot of sedation, or let's say there were other issues with the kid and you wondered whether there was proper signaling going from the brain to the diaphragm, you could say, well, leave them in pressure control and put the catheter in, and let's just see what the EDI looks like. You don't have to keep them in the NAVA mode. And sometimes, even if they're in the NAVA mode, if you're wondering what's going on with NAVA, it doesn't look quite right, and you guys might have done this in the PICU, is, well, let's just put them back to pressure support for a minute. See what he does in pressure support if he's giving us the same problems that he gives us when he's in the mode NAVA. And you might have different ones, but at least you're, okay, now we're back to what we know and see how he's ventilating, and then we can go back to NAVA. So we say, for whatever reason, let's put the catheter in. So we get the catheter, we measure, do all the measurements that we told you about, and we're going to use a 6 French 50-centimeter long catheter. We get the tray, we've done the measurement, we did the calculation. We know that the mark that we're going to put the catheter to will be the, let's say, the 15 centimeter mark or the 18 centimeter mark, and we find that mark and we say, okay, there it is, the 18 centimeter mark, and we're going to put it down. And so we put the catheter in. The nurse, we don't have anything connected. The nurse puts a little air in the port, says, okay, I'm in, I can hear the burp. And then what we do is we connect the cable to the catheter. Okay, and we simply do that this way. And then we would start seeing the EDI occur. But in this case, rather than dropping a catheter in myself to show you what it looks like, we have recordings of patients that are on the ventilator, and I have this cable here hooked into the side of the ventilator, and it's going to be bringing in a patient that was on NAVA. And even though we're talking about babies, I always use this one because I know I'm so familiar with the way the waveform is going to work. It's a 75-year-old female that had pneumonia that was on NAVA. But there it is. So we put the catheter in, he's still in pressure control, but all of a sudden now we've revealed what the electrical activity of the diaphragm is doing. So we see that down at the bottom, and so we see contraction, relaxation, contraction, relaxation. And when we plug the catheter in, see everything moves up and it makes room for the EDI peak and the EDI minimum. Okay? So and that little U, the little U and the V is the microvolts. So remember what I said normal is 10 to 15 microvolts to move a normal tidal breath. So initially we look at this and go, okay, there's the EDI, and before we draw any conclusions to, whether we're right or not, so this is what you would be doing. The problem that you're going to have, if we use it the way we described as just a backup, you're not going to have this, right? But you're still going to have the ventilator to determine the proper positioning. So it's just going to, it's going to be more like this. So your ventilator will be in standby. So in order to see that positioning window, you have to go to the neural access button, which you'll see on your ventilators. This is my teaching screen. It doesn't have it on there, but you press this button, and then you have all these buttons that come up. So you press EDI catheter positioning, and there's our positioning window. So there's the slide that you saw just a minute ago with the QRS. That's actually the P wave, and that's the QRS. So the P wave and the QRS are big. They get smaller, smaller, and smaller from top to bottom, and the P wave disappears at the bottom. So when we see that, we go, all right, we're in the ballpark, right? Now, where is the blue? Well, the blue is in the middle, okay? So we don't have to move the catheter. But if the blue were down, which 90% of the time when you put the catheters in, and the patient does have a spontaneous effort, you'll probably see the blue at the bottom, at the bottom too. Because with that formula being measured perfectly and doing the formula perfectly, I find that for the most part, the catheter isn't in far enough, and you have to always advance it a little bit more than what your predicted mark is. So we end up pushing it down a little bit, and you'll see the blue move from the bottom two to the top two, or the middle two. So once we do that, now we're ready to do NAVA, or we're ready to make some judgment as to, synchrony and those issues that you saw before. So let me start the ventilator up again. But we'll be back on this screen. Okay. So there's the EDI over there, and the blue is in the middle. And now we say, okay, let's just close this out, and let's kind of step back and take a look at this for a minute and evaluate what we're seeing. So when we look at it this way, if this patient were in pressure control, if you can all see the EDI at the bottom, what does it kind of tell you just by looking at this without knowing anything more? What do you see?
We're not synchronous.
You're not synchronous, right? Because here, that might be synchronous, but you may go, well, look, there's the diaphragm moving there, but it moved, if your eye goes up here and here, wow, we were way off here. And in some cases, maybe the EDI moves, but the ventilator doesn't even deliver a breath. So you have a lot of asynchrony. But when you have a real patient here that's triggering the ventilator, it may look a little bit different, but this is somewhat typical. So here, see there, we didn't even deliver a breath there. So we can go back to the neural access button, and we go to the NAVA preview button, okay, this one here. So we touch it, and what I did, and it will always come up with this button activated. In other words, white being activated versus not white being, okay. So it always defaults that way. And it defaults that way because what I've basically done is taken the EDI waveform and I've superimposed it on top of the current pressure wave. Okay. So for right now, I can make this little screen go away, this over here on the ventilator, I can make this go away. So now you can really see how synchronous or asynchronous you happen to be. You know, you were all proud of yourself, oh, we were really synchronous, you know, a baby was fine. And then you put the NAVA catheter and you go, whoa, look at this. The baby's breathing, the diaphragm's moving, but we're not even capturing some of these breaths. You know, and we're going, we had no idea that this was occurring, right? And so here, this might be kind of, here's the diaphragm moving right here, but the ventilator didn't respond, so that's a triggering delay, we could see. And there's another triggering delay. But here, the diaphragm moved, but ventilator didn't even see the effort, didn't even see it. And there was a EDI of 22. That's when the patient took a real deep breath, so his EDI went up, right? The ventilator didn't even capture that. But in real life, I mean, the ventilator would have captured that because it was such a negative pressure probably to do that way. But remember, it's just the simulator. So, so you go, holy cow, we're really asynchronous. So what you could do at this point is if you weren't ready to go to the mode NAVA, you can say, well, he's pretty asynchronous, and you know his blood gases are reasonable here, but maybe we can make him more comfortable by going into the mode and adjusting the eye time or making it a little bit more sensitive. You know, maybe it wouldn't miss those breaths. Maybe we're delivering a little too much pressure. Maybe we can adjust the pressure a little bit. Just try doing a couple of things to the ventilator, and then change the eye time, do some things, and then go here and say, how did we do? Did we do any better? There's that one. That one would be kind of a perfect one in that sense, right? The EDI was right there and the ventilator fired, but no, we're still not looking very good in terms of synchrony. And you could even go to another mode. You can go just experimentally say, well, let's just put them in pressure support for a minute and see if that helps. Go to pressure support. But the point is, you're using this simply as a monitor to try to improve how you set the ventilator. You could also use it to say, well, we know we're asynchronous, but for whatever reason we're not going to go to NAVA, but we're going to give him some sedation now, which will probably knock out his drive. So you have the EDI in there, so you titrate the sedation in until you see the EDI go flat, because by that time you've put the brain to sleep, there's no more signaling, and you go, okay, that's enough sedation, we don't want any more, because we've just given enough just to stop the diaphragm from moving for whatever reason. We've had NAVA used as part of the differential diagnosis to diagnose phrenic nerve damage during surgery. So they go in and they do surgery, but they nick the phrenic nerve and causing right or left hemiparesis. So they wonder, gee, this person's lungs are perfectly normal. But I'm wondering why the EDI is so high. So if only one side of the diaphragm is working, the brain's going, I've got to tell that diaphragm to contract really hard because it has to create the negative pressure that normally the whole diaphragm was doing. So you go, why is the EDI so high? And then you take them to fluoro and you say, sure enough, the one side of the diaphragm is not working. So you can use it for things like that. We had it in a 13-year-old Guillain-Barré patient that initially, when we put it on, the EDI was flat, and we would expect it because he was paralyzed at that point. But a day later, we saw him triggering the ventilator. And when we saw, oh great, he's triggering the ventilator. And I went and I said, how is he triggering the ventilator? And they said, well, he's triggering the ventilator. I go, is he triggering with his diaphragm? And he goes, well, that's how you trigger the ventilator. And I said, do you see an EDI there? And it was totally, it was totally flat. And they went, I said, well, how is he triggering that? It wasn't a leak, it wasn't autocycling. The paralysis was coming back, but he just started to be able to use his accessory muscles. So he was triggering with his accessory muscles, but he had no diaphragm. So he couldn't be weaned, right? Because if you thought maybe he could be weaned, you'd start weaning, but he'd fail, right? But then a few days later, he started using his diaphragm, and they started to see the EDI come back on the diaphragm. So it tells you those things. Another example is where this was at Wake Forest, at Baptist Wake Forest. They had a baby on volume support, basically pressure support, it was a spontaneous mode, and it was the trigger was, you know, purple, purple, purple. The rate was like 56 or something like that, and so we put the catheter in this kid, and the doctor was standing right next to me, and they put the catheter in, and I said, you know, this baby's not breathing. And she looked at me, she said, what do you mean he's not breathing? It's a spontaneous mode. He's been on this mode for a couple of days. I go, no, he isn't. How can he be breathing if he's got no EDI? And she went, what's going on? I said, this baby's autocycling. The ventilator's been autocycling, and they thought he was breathing all this time. And fortunately, the rate at the autocycle was occurring was giving him reasonable blood gases. It wasn't like it was, you know, hurting him terribly. But the point is, they thought he was breathing. And I go, the reason that he appears as though he's breathing is because there's a leak somewhere, and the ventilator is autocycling. And if you seal the leak, when they sealed the leak, after a few seconds, here comes the EDI. Because he wasn't being ventilated anymore, the brain went, oh, well, I better start telling the diaphragm to start, and so the diaphragm started to move. And because he was being over-assisted, and the brain went, hey, I'm not going to contribute to this, you know, problem, so I'm just going to shut down and not tell the diaphragm to move at all. So that's another thing that you can find out when you use NAVA. So it has tremendous power in terms of not only just ventilating people, but telling you other things that you took for granted up until a certain point. So now we say, all right, well, we can't synchronize using the existing mode, so let's just use the mode NAVA. So the rationale might be, if we said to you, you know, if I said, all right, well, I don't like pressure control, let's go to volume control. So the simple rationale would be, well, if I'm going to go to pressure control, or I mean volume control, I want to set the volume at about the same volume as we're currently getting, because after all, the blood gases are, you know, reasonable, and for whatever reason we're going to this different mode. So the rationale for going from pressure control to NAVA would be, all right, well, if I'm going to go to NAVA and I'm reasonably happy with these, you know, the pressures and the volumes, I want to go to about the same pressure that I'm getting now. So how do we do that with NAVA? The way we do that, we go to this button, we go back to the NAVA preview, and here's where we introduce the other button, the only button that you have to learn with NAVA. And the NAVA level is calibrated in centimeters of water pressure per microvolt, which means that for every microvolt that the patient exhibits, we're going to deliver 1 centimeter of pressure support. So in this case, if we were in NAVA and this patient's EDI, let's say, was always 6, he'd be getting 1 times 6 or 6 centimeters of pressure support every breath. Okay, that makes sense to you guys? Now, that's the simplified, and I got into trouble with this because everybody got confused, but that's the simplified explanation to say to somebody if they're standing at the bedside and saying, what is this, how does this, and you say it's basically pressure support, and he's going to get 1 centimeter of pressure support for every one of these for his peak. But in reality, what the ventilator is really doing is it's taking this number and it's subtracting the minimum. So let's say this is 8 and this is 2, so 8 minus 2 is 6, and then it multiplies that number by it. Okay? But for most of the time, when we're not dealing with that tonic activity and all this, this number usually is pretty close to 0, you know, or could be 0.3 or 0.5. So it's negligible. So in that case, you can, with a not very much error, say, well, it's basically just 1 times whatever the peak is. But in reality, what the ventilator is really doing is subtracting the min from the max and then multiplying the number by it. But my brain can't go, 5 minus 2 is 3.2 times 1 is 3.2 centimeters, but I can say 1 times 11 is 11, 1 times 8 is 8, 1 times 7 is 7, 1 times, so I can do that to kind of demonstrate what the ventilator is actually doing. in reality it's subtracting those two, okay? So, here, because we can't do that math that quickly in our heads, you know, if we could, we wouldn't need what I'm going to show you next. But what the ventilator is doing, it is doing that mathematics for us, and that's how it's producing this white line up here. So it's saying that if I was in NAVA now, that currently at a NAVA level of 1 centimeter of water pressure per microvolt, I would be delivering a pressure of, in this case, you know, 1 times about 5 on top of the peak of 5, so my pressure would be about 10, okay? That one now it would be 11, so that's why the pressure peak went higher, and then it was a little lower. So to kind of, what would happen if I turned this to 0? 0 times whatever this number is always going to be 0. So if we move the patient to NAVA now, he would basically be on CPAP. He wouldn't be getting any support at all, because 0 times whatever his EDI is going to be 0, right? So because once again I can't do the mathematics in my head that fast, we'll let the ventilator do it. So as I titrate this number up, you see the white line starting to climb, and so what I want is the peak of the white line to be on average at about the same level as the peak of the pressure of the current, because the yellow line is what we're actually delivering, right? Because we're in just pressure control. So I'll set my NAVA level initially at 2 and then watch it and say, okay, I would have delivered a little bit more pressure. In that case, I would have delivered a little bit less pressure. That one is about the same. So I'd look at this for a number of breaths and say, okay, if I start NAVA at NAVA level of 2, for the most part, he'll be getting about the same pressure that he's currently getting. And so consequently, his tidal volume will be about the same that he's getting, and the baby will be happy. But then his brain might say, you know, I never wanted this pressure. They were making me get this pressure, but the baby, no wonder I'm asynchronous, because I never wanted that pressure. So I kind of fought it, I pushed back, I didn't want all that volume, because that's too much, because I am lung protective. Left alone, I want to be lung protective. So the baby may change and lower his EDI, because now he's in control of how much flow and volume he can get. But he's still going to maintain his life, right? He's still going to maintain volume, so he's going to do and adjust this number against the amount of support that we're giving to always maintain the tidal volume. So this is where NAVA is really cool, because you give control up to the baby, and the baby then will determine what number this will be against this. So if we increase this number, the patient will lower this number, because we're giving more. So if we gave 4 centimeters of pressure support, but the baby was used to this volume and that pressure, the baby would go, whoa, I don't need to deliver or have that EDI so high. So the brain will send less of a signal down to the diaphragm. So 4 times, let's say 2, is 8, which would give him about the same pressure and volume that he was getting. But on the other hand, if I turn this to 1, now I'm cutting my support from 2 centimeters of pressure support to 1 centimeter of pressure support. But if the baby were happy with this, the baby would go, no, I have to increase my EDI to get the same volume. The same idea, it's not hard, but translate it to just plain pressure support, and think about what the brain would do if your baby was happy, but you came along and turned the pressure support up to double what it was. What would his brain, whoa, what's up? He would lower his effort down, because he wouldn't want all that support. But likewise, if you turned your, when you wean, what happens when we wean adults and babies? Well, we're weaning because we're saying, I'm turning the support down, so I'm asking you to do more work. How do they do more work? They increase their EDI, and they're doing more work. If they can sustain it, you can turn the pressure support from 15 down to 10, from 10 down to 5, and then go, okay, they're doing good on 5 with pressure support, they maintain their volume, let's pull that too. So what you're doing by adjusting pressure support is by simply adjusting, or having them adjust their EDI accordingly. So once we're satisfied with that NAVA level, we'll lock it in, and we can close this now.
Thank you.
And now Well, and the reason the white line is bigger in some cases is because the patient is still changing his EDI, right? And it's that number that's giving us that white line, but for the most part, it's at the same peak. So then we go to the mode, go here. Let me go back here and get rid of this. And we'll go here to the mode, NAVA. And so here, there's the NAVA level that we locked in. The peak is going to carry over the FiO2. Remember, it's a spontaneous mode, so there's no rate or anything. And here's that trigger threshold that I told you about. And it's an electrical trigger. So on any particular breath, let's say the EDI minimum is 0, you know, for argument's sake. When the EDI begins to climb up, when it gets to 0.5 microvolts, the ventilator begins to multiply this number by this number as it begins to climb up. Okay? So this is the trigger threshold. When you use NAVA invasively, okay, because you won't see this, you won't see some of this non-invasively, but when you use it invasively, you're always going to leave this number right at 0.5. Never adjust this for any reason. Always keep it at 0.5. There's no reason to adjust it. If you lowered it to 0.3, it wouldn't mean that it would be any more sensitive. It just means that the ventilator would begin to deliver the breath a little bit sooner on its rise up to the peak of whatever it is. Instead of 0.5, it'll say, okay, it's at 0.3, I'm going to begin to deliver the breath now. The problem with putting it at 0.3, for example, and that's why it turns red, is that there may be some noise, electrical noise, that the electrode picks up at 2, which isn't a real breath. But nonetheless, the ventilator begins to deliver 2 times 0.2, and let's say that noise only goes to 0.3. So even though it wasn't a breath and it hardly didn't deliver any support at all, the ventilator thinks that it's a breath. So if you have this breath that's created, but it's not associated with a real intentional breath, the ventilator won't go into backup when it needs to go into backup, right? Because it says, oh no, he's still breathing. So that's why we should leave this at 0.5, you know, because even though there might be some noise, it won't be activated until there's a real intentional breath that brings it up to 0.5. Now the next row of buttons here is the simplified explanation is for in the event that we lose our catheter, that it comes out. The baby is still breathing, right? He's still triggering the ventilator, but instead of getting the NAVA breaths, he's simply going to get plain old-fashioned pressure support breaths. And he's going to get pressure support and a pressure support of whatever you set, and so you can go, well, if we did have that, we lost the catheter, we'll set and we'll deliver the same pressure support as he's currently getting, okay? And we'll cycle off at 30%, so this is just plain pressure support. The thing is that you'll always want to set your pressure support trigger at -2. It will default to 5 like it does in all the modes, but you always want to set it at -2, because this then, in the event that there's some leakage and auto-cycling occurring, you don't want the ventilator to be triggering on the negative pressure trigger or the flow trigger before the EDI min gets, or the trigger threshold is met. Because if that's the case, the ventilator then, if the phase shift is enough, the ventilator will begin to auto-cycle, cycling off of the pneumatic trigger, and it'll say, I'm confused, should I be triggering off the real diaphragm, or should I be triggering pneumatically? And so what'll happen is the ventilator will go into NAVA, and you'll see parenthesis here, NAVA pressure support. So, go ahead.
No, she was just wanting to remind you that
This is,
No, I
right,
know.
this is
I
for
know.
invasive only. So I'm
Yeah.
going through the whole theory of
Just
NAVA,
in case
just so
whatever
you get
comes
the
up, I actually remember.
full, but then I'll condense the whole in-service
It'll be a
down into
long
about
time to
5
remember.
minutes, and then we'll see what we're gonna use it for.
Yeah.
Now, in the event that, so that's the way we set these. Now, then the next level is our backup. So in the event that we're breathing, remember it's spontaneous, but there is a apnea, the ventilator will go to a pressure control of whatever you set. Let's say we'll set 13 at a rate of whatever you set, at an I time of whatever you set, just kind of like the way backup pressure support works. And then when he starts breathing again, he will go right back to NAVA, and then he'll go back and forth, just like version 6.0 does on pressure support. That's what we've been upgrading your ventilators for. So once we set everything the way we want, we touch accept, and now the ventilator is in NAVA. Okay, so now whenever the EDI triggers, notice the difference in the trigger. It's a pink that's really pink or a lighter purple as compared to that purple. See the difference? Pink versus.
Sucks if you're colorblind.
Are you anybody colorblind? Okay.
Well,
So that's a pneumatic trigger, that one. See, and see that? The ventilator says the pneumatic triggering is occurring faster than the EDI, so see how it switched to PS? Now what's going to happen is it goes to backup just for an instant, but then it says, oh, there's the EDI, so I'll just go back to NAVA. So sometimes it cycles through like that. So, so the EDI, when we're picking up the NAVA, the EDI, the little pink will be on the EDI rather than being pink on the flow or the pressure wave, like it would be normally in normal ventilation. Okay? So this is NAVA. Notice the similarity between the rise in the EDI and the similarity here, so we have perfect flow synchrony. And so now the baby would be more comfortable, more synchronous, and if we then played with the NAVA level and said, all right, let's see how responsive that neuroventilatory coupling mechanism is. Let's see what happens if we turn the NAVA level to, 1. You should see an almost immediate rise in the EDI because the patient was going, I was kind of liking that, so the EDI will begin to trend up a little bit. If on the other hand you were at 2 and you said, let's turn the NAVA level up to 3, the EDI will come down and you'll see the baby doing less work. So we can load or unload the patient by increasing or decreasing the NAVA level. That's our, but in a lot of cases, once you set this NAVA level, if you improve efficiency, in other words, the patient gets more comfortable, the diaphragm relaxes, after some time you'll see that the EDI begins to come down without you doing anything to the ventilator, because now the brain goes, oh, it's a lot easier to breathe. I don't have to tell the diaphragm to contract as much. And so now we can say, well, how much pressure support are we delivering? Remember, the formula will be basically 2 times whatever this number is, will give you the amount of pressure support, which when you add to the baseline of 5, will give you that number. Follow that? Remember, the reality is it's really this number minus that number, but I'm just saying if this is 0, 2 times 10 is 20, plus the 5 a PEEP would have given us on that breath a PIP of 25. 2 times 8 plus the 5 a PEEP on that breath would have given us 16, or 21. 2 times 4, 8 plus 5 would have been 13. Okay? Now another way that you can do it, rather than doing the math this way, just say peak pressure 15 minus PEEP of 5 is 10, so on that breath he got the equivalent of 10 centimeters of pressure support. On this breath, 28 minus 6, he got an equivalent of 22 centimeters of support. On this breath, he got 20 minus 5 or 15 centimeters of support. That math, doing it this way, would work out to be exactly the same as working the math this way, in terms of how much pressure support the patient gets on each individual breath. So if somebody were to say, what is NAVA the most like in terms of modes that I understand, say it's just like pressure support. But it's variable pressure support. And the variability comes from how the brain wants any particular breath by raising and lowering this number against what our fixed NAVA level is. Okay? So this is where we would use, and if we wanted to force a wean, we could say, all right, well, the baby's been on 2 centimeters support for a couple of days now. Let's see what happens if we turn him to 1. We know or suspect that his EDI should go up, but that's okay. He's going to be doing more work. The question is, can he do the more work for an extended period of time? That way we've turned his support down. If we end up turning his support to, let's say, 0.2, if the NAVA level stayed at, let's say 6, 0.2 times 6 is 1.2, right? 1.2. So that means he's only getting about 1.2 centimeters of pressure support. Okay? Negligible pressure support. Doesn't even need to be on the ventilator. Now we're getting into what you're going to be using NAVA for. Okay? So when we go to non-invasive NAVA, understanding that when your NAVA level is at 0.2 or 0.3, you know, assuming a normal, relatively normal EDI, for example, in a COPD patient, an adult patient, if he's in respiratory failure, we've just intubated him and we're going to put him right on NAVA. We put the catheter in. We may note, because his diaphragm now, the electrical activity of the diaphragm had gone so high, but the diaphragm was not efficient, you might see an EDI of 70 or 80 or 90 or 100. I've seen babies with an EDI of 100. What would you put the NAVA level at if the EDI was 100? Well, just from what I told you, you wouldn't put it at 1, right? Because 1 times 100 is 100 centimeters of support. That would be outrageous. So you go, well, I'm going to put it at 0.1, or let's say 0.2. 0.2 times 100 is 20 centimeters of support. So for that COPD patient at that time, 20 centimeters of pressure would probably give him some reasonable tidal volume. And then his brain goes, oh, okay, I'm getting the volume, good. And the CO2's coming back in line. The diaphragm I don't have to tell the diaphragm to contract as hard because I'm getting the volume. The diaphragm begins to recover. The EDI goes from 100 down to 80 or 70, right? I mean, very quickly, because 0.2 times 70 now is 14. 14 centimeters of support is producing the same tidal volume as it took when his EDI was 100 because his diaphragm was so fatigued. Right? But what I'm talking about is a baby on bubble CPAP who presumably, because he's on bubble CPAP, is ventilating okay, that you wouldn't find that his EDI would be 20 or 30 or 40, because if it was, you would have noticed, man, he's really working on bubble CPAP. I don't know, he's not doing well, so I don't care about the apneas. I mean, he's really not ventilating well. But if he's on bubble CPAP, but he's just having the apneas, it's most likely that his EDI is going to be relatively normal, 10 to 15 microvolts, somewhere in that range. So 0.2 times 10 is only giving him 2 centimeters of pressure support, right? Which is negligible pressure support, right? So what we would do is we'd have him in non-invasive. We put the catheter in, let's say he's still on the bubble. So here are the easy steps. If I didn't explain to you anything about NAVA, this is what you do. You go to non-invasive NAVA. You set your NAVA level at 0.2, minimal support, assuming that his EDI is 10. Set your PEEP wherever your CPAP is, 5 a PEEP or 6 or 8 or whatever it is. Set your FiO2, leave your NAVA trigger the same, and then you say, okay, if he does have apnea, how much pressure do I want to be going through the prongs, knowing that it will only be for a couple of breaths, because all this is for is just plinking the baby's heels. So, let's set a pressure control of 8. Okay, so we'll get 8, right? What rate would you want him on if he were going to be on backup, but he's knowing that he's not going to get 30 breaths because he's only going to get 2, and he's going to go right back to NAVA or right back to bubble, this sophisticated CPAP. So it really doesn't matter where you set the rate, and it really doesn't matter. You can set an I time, of what you're used to, setting 0.4. So then when you accept it, now when you go to this mode, you might have to turn your alarms off. Oh, I don't want to turn that on. So here, there's the EDI. He's getting a little bit of support. See how little the pressure wave is? He's just getting a little bit of support, but now he has a period of apnea. So what's going to happen? So each one of these hash marks is 1 second long, so this is a total of 10 seconds. So if you're watching this and his apnea starts here and it just is flat, 10 seconds later, he goes to these settings. Ventilator alarms, goes to backup. It says NIV NAVA backup, and you'll see backup here. And then the ventilator will start, will go right back to NAVA when he starts breathing again, after he gets hit with a couple of these breaths to stimulate him. And then later he'll stop again. Now, the lesson here, or what you have to do is say, all right, I had my apnea delay set at 10 seconds, but I noticed that he had some desaturation before it went to backup. So what would you do? Decrease this to 8, right? So now it goes to backup at 8 seconds, and you go, did he have any desat or braiding? No, he was good. Okay, that's the point at which you want to be. But now, we say, then the nurse comes back to you a little while later and says, you know, this kid has these periodic breathings and goes to backup like 8 times every half hour. It's driving me crazy because every time he does it, the ventilator alarms, right? Is there something you can do about that? I said, well, no, we want the ventilator to go to backup, right? So I'm going to leave this alone. But what you can do is go to this button called the apnea audio delay. So now, the ventilator still goes to backup at 8 seconds. But if he stays in backup for longer than 10 seconds, the ventilator will start alarming. It won't alarm, it will say backup, red backup, but it won't begin to audibly alarm for 10 seconds after the 8. Okay? So if you were in the room and you heard the apnea alarm go off, the kid would have been apneic for 18 seconds at that point. But he would have been backed up at 8 and still not breathing. He never returned back to the spontaneous mode. So initially, when non-invasive NAVA first came out, we didn't have this button. And oh my God, we're getting called every other day. People are going, we love NAVA, it's great for the kids, but the nurses are going to kill us because the alarms are going off all the time. So they said, oh, what if we put an audio delay on the apnea alarm?
But you can still go in and see if it's doing that.
Yeah, yeah. So now you go, well, I want to see how many switches to backup he's had. So what you can do is go to your trend screen and go down, and by the way, there's your EDI. So you can see what his EDI does over time. You know, if it goes up, you know, is he working harder, working less? You can see what his peak pressures are based on that EDI. But as we go down here, there we have switch to backup, and then how long of a percent per a minute were you in backup. So here you'll see these little marks. We don't have any yet, but we see these marks, and we go, all right, he had one here, one here, one here, one here, and this is, let's say we set this at, okay, there was a switch to backup. That's what it looks like. So we had a switch to backup at 3:32, and he was in backup for 3% of 1 minute. Basically nothing. So what would happen then, you know, the first day you see this and another one and another one and another one and another one, so you go 1, 2, 3, 4. He had 8 switches to backup in from 240 to 340. But when he did switch, it was only long enough to get a couple of breaths, and he switched right back to NAVA, spontaneous. So then the next day you can come in and go, well, I've been off, or I just came in, I was working yesterday, I came back in. How many apneas or switches did he have last night? You go in and you look at a 12-hour window, and you say, well, he only had, 5 switches to backup all last night, but the night before he had 15 or whatever, you know, so you can kind of get a gauge on whether he's maturing in terms of his number of switches to backup. But then you also then have to say, well, all right, well, he's having few switches, how can he tolerate them better? So you say, well, he doesn't have DSATs or Brady's, but it might be hard to tell because his apnea delay is set at 8 seconds. So today, why don't we set his apnea delay out to 15 seconds and see what happens? So when he does have one of those switches, can he tolerate it as a normal baby would tolerate it without having a DSAT or a bradycardia? So the weaning, you know, you're in essence, whoever heard of weaning apnea times and all that? But here what you're doing is weaning an apnea time. But you're only using NAVA you're not using NAVA as a ventilatory tool because he's on 21% and he's getting essentially 2 centimeters of pressure support. He doesn't need ventilation at all through this system that you have. What he needs is, every time he went to backup, he desatted. So the ventilator is just flicking his heel. So all the discussion about, oh, if we want to make him breathe easier or breathe less, turn the NAVA level up or down, you'll never touch this NAVA level because all you're using it for is basically mimicking bubble CPAP, but now you have this sophisticated backup that goes to this backup and gives him puff through the nose. So it took us, 4 hours to get to this point, but basically, here's where the problem I see comes in terms of what we really should do is, in my opinion, say, all right, get the servo, we're going to put them on NAVA. So you get all this set up and disconnect the bubble, and you put him here. So now he's just on. Let me get rid of this. So now he's just on nasal CPAP. You put the catheter in and you see the EDI down at the bottom, but there's really no way to do that synchrony to see if he's synchronous because you could, I suppose, you could go here, catheter positioning, sorry, wrong one. Go here. Whoop, he had apnea, right? But he didn't, there was no backup. So here he's breathing, so you see the EDI against what you can kind of determine to be the pressure changes associated with CPAP, the little blips. And so he's, but you would probably see perfect synchrony there because every time he did breathe, you'd see a little pressure movement. And you go, all right, well, he's in the end CPAP, but we want to protect him, so what do? So you go here, you don't have to go to that NAVA preview screen to set the top of the white line at the same level because you're not going to be providing any. You see that he's got a relatively normal EDI, so just go here, go to non-invasive NAVA, set your NAVA level at 0.2, his PEEP at 5, and his trigger, set the backup where you want, and just touch accept, and now he's in NAVA. But he's got that backup. Okay, so that's the long and the short of it.